This recorded lecture will be going over Chapter 21, The Child's Experience of Hospitalization. Satellite clinics are convenient and offer families flexible coverage. Some are located in shopping malls. Another area of outpatient care is the Pediatric Research Center. This type of institution offers highly specialized care for patients with particular disorders, often at little or no expense to the patient. For patients with uncomplicated conditions, elective surgery at an outpatient surgery clinic will offer the advantage of lower cost, a reduced incidence of healthcare-associated infection, and a recuperation at home in familiar surroundings. The attitude of nurses, receptionists, and other personnel in the clinic, office, or hospital unit is of the utmost importance. Whenever possible, the parent should be involved in the preparation for and initiation of a treatment or procedure, and the child should be prepared according to his or her developmental level. You can read a little bit more about this on page 480 within box 21.1. Because hospitalization is now brief for most children, the choice is not either hospital or home care, but a combination of the two. The child's reaction to hospitalization depends on many factors, like age, amount of preparation given, security of home life, previous hospitalizations, support of family and medical personnel, and the child's emotional health. Each child reacts differently to hospitalization. Children may see the nurse as someone who cares for them physically, as their parents would, and as a source of security and comfort. The major cause of stress for all children of all ages are separation, pain, and fear of body intrusion. This can be influenced by the child's developmental age, the maturity of the parents, cultural and economic factors, religious background, past experiences, family, size, state of health on admission, and other factors. Separation anxiety typically occurs in infants age 6 months and is most pronounced at the toddler age. There are 3 stages of separation anxiety: protest, despair, and denial or detachment. If the detachment stage is prolonged, an irreversible disruption of parent-infant bonding may occur. The nurse must understand that the child who is in despair will revert back to the protest stage when the parent arrives for a visit. Rather than showing joy, the child will cry loudly when the parent appears at the door, and this is good. Optimally, the nurse should help the parents understand they should not deceive the child into believing that they will stay and then sneak out while the child is distracted. This can tear the bond of trust. Infants cannot show the nurse where it hurts, and often a child's report of pain is not given the credibility of an adult's report. Comfort measures and distractions are the initial interventions for mild or temporary pain. The nurse should ask the child about pain using a pain rating scale. In infants, pain can be assessed according to a behavior scale that includes tightly closed eyes, clenched fists, and a furrowed brow. A pain indicator for communicatively impaired children has been developed and includes observations rated on a 4-point scale. The FLAC scale is a pain indicator that can be used with nonverbal children. Non-pharmacological pain techniques like drawing, distraction, imagery, relaxation, and cognitive strategies can enhance analgesia to provide necessary relief from pain symptoms. In newborns and infants undergoing brief painful procedures, oral sucrose can provide some analgesia. Pain medication should not be withheld from infants and children when needed. Elimination of the drug from the body may be prolonged due to an immature liver enzyme system. Dosages will be influenced by weight and differences in expected absorption, metabolism, and clearance. The nurse should calculate every medication to determine the safety of the dose before the medication is administered. Acetaminophen is commonly used for the relief of mild to moderate pain in infants and children. NSAIDs, like ibuprofen, will be given in a maximum dosage of 8 to 10 milligrams per kilogram every 6 hours. Opioids are used for moderate to severe pain, like post-op pain, sickle cell crisis, and cancer. The right dose of an opioid drug is the amount that relieves the pain with a margin of safety for the child. The dose should be repeated before the pain recurs. Fentanyl is a potent analgesic given for short surgical procedures. Naloxone should be available for use in case of opioid overdose. Local anesthetics are used with safety and effectiveness in children. Topical anesthetics are used for skin sutures, IV catheter placement, and lumbar punctures. Parents and children as young as 7 years old can be taught to use a PCA pump. Any child receiving opioid analgesic drugs should be observed closely for side effects like respiratory depression. More effective pain relief at lower dosages can be achieved when a low-dose analgesic is administered around the clock on a regular schedule rather than as needed. The nurse should provide detailed observation of the child's responses to the medications and note, record, and report any side effects. Conscious sedation is the administration of IV drugs to a patient to impair consciousness but retain protective reflexes, the ability to maintain a patent airway, and the ability to respond to physical and verbal stimuli. Conscious sedation is used to perform therapeutic or diagnostic procedures outside the traditional operating room setting. A 1-to-1 nurse-patient ratio is continued until there are stable vital signs, age-appropriate motor and verbal abilities, adequate hydration, and a pre-sedation level of responsiveness and orientation. Regression of growth and development during hospitalization can be expected. An accurate nursing assessment of the child's abilities and planning of care to support and maintain growth and development can minimize regression. Regression should not be punished. Nurses can guide parents to praise appropriate behavior and ignore regressions. Showing culturally sensitive attitudes towards families with hospitalized children will reduce anxiety. The nurse should be aware of telephone language lines in addition to mobile telephone apps and computer technologies that can be used to communicate effectively with patients and families. Family members should not be used as interpreters because there's a risk of information being lost in translation, especially if the technical language is not fully understood by the interpreter. Nonverbal cues and body language are important in intercultural communication. Protective amulets or charms placed on the wrists or clothing of infants must be respected. If the practice is based on cultural belief, the practice should be respected and no attempt be made to change it. Personal space is defined as an imaginary circle that surrounds us. The size of that space and how securely it is guarded is largely determined by culture. A smiling nurse may not be received in all cultures as a friendly nurse. Touch can give misleading messages. Teaching strategies must be designed to approach the topic from the perspective appropriate to that culture. When teaching infant care and child care, the nurse must always determine the values of the cultural practice of the family before imposing a standardized process. When children are hospitalized, the entire family is affected. Even in cases of child abuse or neglect, nothing will be gained by blaming the parents. The nurse should remain objective and empathetic. The nurse encourages and supports parents and other family members, stresses the importance to the child's recovery, and encourages their participation in the care of the child. The nurse should remain relaxed, reassure the parents, and reinforce positive parenting. Information about the child's condition and the treatment plan are given. Poor communication will result in unnecessary fears. The care and welfare of the other children at home while one parent is at work and the other is rooming in with the ill child should be discussed. The nurse must not pass judgment on individuals whose behavior may seem demanding or unreasonable. Siblings will also be affected when a brother or sister is hospitalized. They may be afraid or feel left out, guilty or resentful of the attention and focus on the ill child. Ideally, the parents and child should tour the pediatric unit before admission. Between 1 and 3 years of age, children are worried about being separated from their parents. After 3 years of age, children may become more fearful about what is going to happen to them. Parents should try to be as matter-of-fact as possible about this new experience. Perhaps listening to how the child feels and encouraging questions will be more important than explaining certain occurrences. Parents should never lure children to the hospital by pretending it is some other place. When the parent tells the nurse the child's name, associating it with a familiar person who has the same name will help the nurse remember it. The parent should be encouraged to do as much for the child as possible. Calmness is catching. When children are hospitalized, the nurse should be aware of a developmental history as well as a medical history. Developing the pediatric nursing care plan will be similar to developing an adult care plan. A nursing diagnosis for a pediatric patient can require some modification. Hospitalization is frustrating for infants. Nursing personnel should try to meet the needs of these patients by protecting them from excess frustration. One of the nurse's major goals during this period is to assist with the parent-infant attachment process and promote sensory motor activities. The nurse should administer uncomfortable procedures as gently as possible and return the infants to the parents for consolation. Consistency in caregivers is also important at this stage in development. Hospitalization is a painful experience for toddlers. They don't understand why they're separated from their mothers and they become very distressed. Separation anxiety is at its peak in the toddler. Repetitive games involving disappearance and return can be helpful. When the nurse or parent leaves, they should explain when they will return in terms that the toddler could understand from experience, and then promptly return at that time. Rooming in is highly desirable. The nurse must also realize that parents are under stress and should not be asked to assume responsibilities beyond their capabilities. Children should be forewarned about any unpleasant or new experiences that they may need to undergo while being in the hospital. Supervised playroom activity will contribute to intellectual, social, and motor development. When restraint is required, it must be accompanied by increased emotional support, such as rooming in, additional attention from nurses, and suitable diversion. The experience of hospitalization may be easier for preschool children who have already had outside contact than for those who have never been separated from their parents. Because children of this age operate with concrete thinking, they can understand more and be better prepared for hospitalization. Explanation should be made in realistic terms because preschool children cannot understand abstract explanations. They should be made to realize that hospitalization is not a punishment for something they've done wrong. At this age, the child is afraid of bodily harm, particularly invasive procedures. Children in this age group will engage in magical thinking and fantasy. Children of school age can endure separation from their parents if it is not prolonged. The school-age child is in a state of industry and independence. Forced dependency of the hospital can result in a feeling of loss of control and loss of security. The education of the school-age child must continue throughout any illness. This gives the child a sense of continuity with the outside world, provides periods of socialization, reinforces weak academic areas, and reassures the child that he or she can return to their peers after discharge. Diagnostic tests and treatment should be scheduled around established school routines whenever possible. Adolescents in particular will experience feelings of loss of control during hospitalization. When feelings of independence, self-assertion, and identity are threatened, the adolescent may respond with withdrawal, noncompliance, or anger. Nursing care plans should be oriented to the adolescent's age. The adolescent has many intellectual strengths, including the ability to think abstractly and solve problems. Roommate selection, although often overlooked, is extremely important for this age group. Adolescents usually do better with one or more roommates than in a single room. Respecting the confidentiality of children is important in establishing trust. In general, information should not be divulged or shared without consent. The term emancipated minor generally refers to an adolescent younger than 18 years of age who is no longer under their parents' authority. Married minors or minors in the military are automatically considered emancipated and may give consent for medical treatment for themselves and their children. In a medical emergency, a minor can be treated without the consent of parents if the situation is life-threatening. Preparation for the patient's discharge ideally begins on admission because the goal of hospitalization is to return a healthier and happier child to the parents. If a patient requires specific home treatment, like hyperalimentation, colostomy care, crutches, special diet, or insulin therapy, instructions should be given to the parents gradually throughout their child's hospitalization. The instructions should be written so they can be referred to as needed. Parents must also be prepared for behavioral problems that may arise after hospitalization. Whenever possible, parents should be provided at least 1 day's notice of their child's discharge from the hospital so they can make necessary arrangements. The healthcare worker assisting in the home should observe how the parents interact with the child. Observe facial expressions and body language. Post signs above the bed denoting special considerations. Listen to the parents and observe how they attend to the physical needs of the youngster. Ask questions or discuss apprehensions that the parents may have about their ability to care for the child. Be attuned to the needs of other children in the home. Be creative in exploring avenues for socialization, and explore community facilities or support groups that may benefit the family.